Knee pain is one of the most common sites of joint pain managed in general practice. In patients over 50, this usually comes from the slow erosion of the cartilage cushion in the knee joint from wear and tear over time. This is called knee osteoarthritis. Thanks to the great work that's being done by first contact practitioners, practice-based paramedics, and physicians associates, you may find yourself less involved in the assessment and diagnosis of this condition. Instead, you're contacted at the end to prescribe a treatment for it. But did you know that the role of prescribed medicines is becoming less and less convincing for this condition? There's 3 groups of lifestyle modifications that have a much better evidence base than any tablet, gel, or injection for managing knee osteoarthritis pain. And overlooking these and diving in with a prescription could deny your patients their benefits. So let's learn more about them. The first is termed activity modification. And all this means is we substitute activities which put extra strain on the knee joint with ones that don't. In terms of exercise, this could mean replacing high impact movements like jumping with low impact ones like cycling, swimming, or elliptical exercises. Alongside exercise, it's always worth exploring occupational modifications. Some simple adjustments like using knee pads or cushions can massively minimize any further damage to the knee. To get a feel for this, you could ask patients, is there anything in your life that you think is putting extra strain on your knees? The second can be difficult to approach, but weight management can have a huge impact on knee pain. Every kilogram lost in body weight takes 4 kilograms of pressure off the knee joint, so even small bits of progress with weight loss can have a huge impact overall. We're doing our patients a disservice if we don't cover this in our consultations. And the level of weight reduction with the best evidence base is a 10% reduction. So it's worth setting this as a target and getting help from your social prescribing team to get there. Deprescribing has a huge role in this. You may encounter patients on drugs that are strongly associated with weight gain, like pregabalin or mirtazapine. And if you're in a position to reduce their dose or come off these altogether, it could really help them with their weight loss journey. The final of the big 3 really needs the expertise of our physiotherapist colleagues to implement, and this is called therapeutic exercise. This focuses on strengthening the support muscles around the knee through low impact aerobic activity or resistance exercises. Activities like yoga and Tai Chi are great for this, and there may be many local classes in your area that the social prescribing team could link the patients in with. So after all that, we can finally start looking at the medications. And to me, the only role for these is helping patients through the lifestyle interventions we've just gone through. There's lots of treatments out there and it can be difficult for patients to make a decision about their knee osteoarthritis, but thankfully NHS England has made a great document called Making a Decision About Knee Osteoarthritis. This is aimed at patients, but I guarantee it'll tell you something new about the management of knee osteoarthritis. My favourite section is towards the end, where it summarises the evidence for each intervention. Looking at this page, you may be surprised to see that the top treatment is the treatment that also has the lowest risk of harm or side effects, topical NSAIDs. This is better than oral NSAIDs, better than codeine, better even than joint injections, so don't overlook these valuable treatments. Response is very individual, so it's really trial and error finding the right one for your patients. The evidence base is best for diclofenac gel and ketoprofen gel, but a lot of your patients will find ibuprofen gel is the one that works best for them. Whilst the evidence isn't brilliant for the other options on the list, there is a chance that each of these could be really helpful for your patients. For example, oral NSAIDs have a really useful role if someone has multiple joint pains, particularly if the hips are affected, as topical NSAIDs are less effective for this type of pain. Low-strength opioids have a role if patients are struggling with the therapeutic exercise despite the topical NSAID, but I always emphasize that this is intended as a short-term course. It's really important that we keep receptive to options that aren't included in this document too. A recent Cochrane review explored whether low-dose amitriptyline could help with knee osteoarthritis, and whilst the outcome was variable in some patients, certain people experienced a massive improvement in pain after this was introduced. Anecdotally, the groups I feel most likely to benefit from this would be patients with superimposed sciatica pain or those whose pains disturbing their sleep, as the drowsiness amitriptyline causes can help with this. The key message here is it's low-dose amitriptyline. Amitriptyline can lead to profound weight gain, particularly at higher doses, so I would recommend patients stay below 50 milligrams, but bear in mind that amitriptyline can do that at any dose. So there you have it. You now know that before you write any prescriptions for knee osteoarthritis, you'll discuss these 3 big lifestyle interventions first. This will have a huge impact on your patients and their quality of life, reducing the number of times they come to the practice or specialist visits as well. For the next video, I'm going to provide you with 3 acronyms that I feel will get you through 90% of the questions you'll ever get asked about medicines. See you then!